It's Jason here from DoctorPremed.com, here to talk to you about my cardiology elective, which I just completed. And that rotation was 4 weeks in duration, and it was split with 2 weeks of outpatient in the office and then 2 weeks of inpatient in the hospital. And cardiology has always been a specialty that I've been somewhat interested in. So it was great to really kind of get an idea about what's going on in the specialty. And my overall impression was it's something that I would definitely consider doing. And inpatient, that's very complex. You have a lot of things going on. You have patients who are extremely sick. And what happened at the hospital that I was at, the physicians, they would round at about 8 o'clock in the morning and they would round into noontime. They would see all the patients in critical care, patients who were just there for observation, or if on the floor of the hospital any of the other specialties needed any consults for anything that was going on. And what's kind of funny about that was some of the consults, one of the physician assistants is like, who do they think we are? Just because a patient has a heart doesn't mean that they need a consult. And so that's kind of funny that you see a little bit of that. And then even when you have in the hospital, you're going to have emergencies, MIs, heart attacks. And so there were times when a physician's pager would go off and they would let us know that we had a STEMI that was 5 minutes out from the hospital. So we had to get down to the emergency room to do an assessment on those patients and to determine what type of treatment that they would need, whether that would be medication or whether they need to go immediately to the cath lab. And so we did a lot of that. And then let me talk a little bit about the cath lab. The cath lab is very interesting. That's totally procedure based. And we did a lot, if you have chest pain or other indications that would require that you would need a catheterization, we would do that. And there's two formats of doing a catheterization. The main way that you do it is through the femoral, through the groin. And another way for a cardiologist to do a catheterization is the radial way, which would be through your wrist. Obviously, depending on your level of health and status, we would determine which would be the most appropriate format to do a catheterization for you. And it's very interesting. You have to wear, it's called lead vest because you're taking, there's a lot of, I don't want to say radiation, but they're taking a lot of films and pictures. So you want to protect yourself from exposure to that. So anybody who's in the cath lab, they would wear a lead vest while the physician is taking images, because as you're threading the cath through the arteries and veins to the heart, you need to see where you're going and you take images of that. And a lot of times then you would inject a dye into the vasculature, and that's going to give you information as to whether there's an occlusion or not that needed to be open. And what was interesting is you have invasive cardiologist and then interventional cardiologist. An invasive cardiologist, he or she would be the one that would go in, do the catheterization, but with the catheterization would be with the dye, but then your interventionalist would be the one who would actually place any stents if they were required. So I thought that was very interesting, that distinction between the two, because you would almost think that if you were the one putting in the dye, why wouldn't you be able to do that last final step of putting in the stent or opening up any of the vessels or arteries that were clogged? But that's not how it works. And then you also have your pacemakers and implantable cardiac devices that patients would need. They would need a pacemaker, and then also sometimes they would need a defibrillator. And a pacemaker obviously just going to keep the rhythm of the heart. If, let's say, you set it for 55, so if the heart goes below 55, then your pacemaker is going to go off. And then other times you have a defibrillator, that's if you have an irregular rhythm, you need to shock it back into the right rhythm. That's where your defibrillator works. So those are two different type of devices that you use in cardiology. And then also you have a lot of times some people come in with an atrial fibrillation, which is a rhythm that's wrong. And how you would fix that, you would give them some medicine, try to give them their rhythm back, but sometimes they just stayed in AFib, is what we call it. You have to do something more aggressive. And for the cardiologist, that would mean you would do a cardioconvert, where you would basically sedate the patient, and then you're going to send them a huge jolt of current in joules. So all you physics people, that's what you're using. It's going to be joules. So we did that on a couple patients. And I actually had the privilege of being allowed to shock the patient, where you do the clear, clear, make sure the room's clear, and then hold the shock button and send a bolt of electricity to the patient. And so that was very unique, rewarding experience. And it was great that the patient, they were shocked into rhythm. And I should mention that when you do this, they're under anesthesia, so they're not awake, they're not aware of what's going on, because obviously that could be very traumatic for you if you're going to get shocked with electricity to get your heart back in rhythm. And overall, I found the hospital very enjoyable. Obviously, as a medical student, I wasn't working any crazy hours or anything like that. It was pretty decent, but the doctors were on call. They had a lot going on. And one night, the doctor said he was on the phone taking care of consults from like 2 in the morning to 6 in the morning, because one of the patients was coding about 3 times throughout the night. And so obviously he was needed for that. And there's enough staff where he didn't actually have to go into the hospital to physically do anything, but there are times as a cardiologist when you will be sent into the hospital to do procedures in emergent setting for patients, when depending on what's needed of them. And so that's basically a general overview of cardiology from the hospital standpoint. In the office, that's basically you're seeing patients from about 8 in the morning to about 5 in the evening, and those slots are usually about 30 minutes or so. And a lot of that's basically like wellness visits, checkup, making sure everything's going all right with the patients. They usually have established care, so you want to listen to see for any murmurs and any other deficiencies that a patient may have, and also advise them if you need to do any testing, like an echo test, a stress test. And it's the cardiologist, so every patient, before you see the cardiologist, you're going to get an EKG by default. And if you're a student and you want to know more about EKGs, you definitely want to get your hands on Dubin's book for reading EKGs. That's like the gold standard for any medical student or anybody who wants to be more proficient in EKG readings. And I actually was reading that book, found it very enjoyable, got a lot out of it. And I'll tell you, even if you're not thinking about going into cardiology, it's a good idea to know your EKGs, because whatever specialty you go into, you're going to people are having heart, they're going to have heart issues that are going to come up, and you want to know what type of information you want to convey to your cardiologist. Because one of the cardiologists said, I know you're a medical student, but as you progress throughout your career, there's certain things that we expect of you. I expect more out of a resident than a medical student, and I expect more out of a senior resident than a junior resident. And he's like, if you give me the wrong information over the phone, he's like, you better believe I will chew you out, because there's certain things that at your academic level of experience I expect you to know, and you're doing myself and yourself a disservice if you can't even give us basic information. And one of the things, so that's just something to keep in mind. And one of the things is murmurs. Though those are very, very hard to distinguish, especially diastolic murmurs. Those are tough even for practicing physicians who have a lot of experience. They have trouble listening to it. And as a medical student, sometimes it's very hard when your attending goes, listen to this patient, and then they ask you, what did you hear? How did it sound? And you're kind of at a loss for words and kind of need some help. And so it just depends on the teaching style of the attending. Some will say, okay, this is what you're listening for. Tell me if you heard it. And that kind of helps out as a medical student, because a lot of times you're not going to really hear what they want you to hear, just because you don't have that experience, depending on the grade of the murmur. Obviously, if you go up to like a 3 or 4 grade murmur, you definitely should hear that. But anything lower than that, like ones, zeros, ones, and twos, might be a little bit difficult for a novice medical student. But the key way to do it is just more practice with it. And that's one of the reasons why I did the elective rotation cardiology, because it's not my strongest area, and I wanted to get more experience in that area. And the personalities of the cardiologists, everybody has a different personality, but I found the group to be very enjoyable. They all got along with each other for as far as I could tell. They were very down to earth. But what was interesting, though, I have to say this is I asked some of the attendings, like, so why did you decide to go into cardiology in the first place? And one of the attendings goes, well, I was looking around and all the cardiologists seem to be the smartest physicians, so that's why I went into cardiology. And I thought, wow, that's very arrogant and confident to say something like that. But like, when you think about it, cardiologists, they are pretty smart. There's a lot that's involved with the heart, and they got a lot of consults that go along with it. And with cardiology, it's interesting to know that when you have patients who have cardiac issues, you don't necessarily group them as saying, oh, it's a cardiac issue. The one corresponding issue that goes along with cardiac could be pulmonary, so that's your lungs. And so there's a lot of going back and forth trying to determine, is the patient shortness of breath due to a heart issue or is it a pulmonary lung issue? So that's one distinction that you have to make. And definitely know your cardiology drugs, because as a patient age, the population's getting older, you're going to see more and more patients on cardiovascular drugs. So even if you're not a cardiologist, you want to know what your patients are taking and how it affects them. And people are living longer. We obviously know that, but one of the things is there's a lot of cardiovascular disease, and it's kind of unfortunate when you see patients who don't take care of themselves and they're on these medications, and they might even be in their 50s, 60s, and we have to tell them you're going to be on this for the rest of your life. So if you're a young person or anybody out there, make sure you're doing everything possible where you're not going to be in an unhealthy situation where you're going to need medication for the rest of your life, because it's not something that you want to do. And a lot of the hard stuff, you do your exercise, you can totally avoid it, eat well. But if there's genetic components, obviously that's going to be a factor. But if you're a smoker, diabetes, that's really going to put you at risk if you have family history and things like that. So anything that's modifiable risk factors, you want to do everything in your power to change that and not let it happen to you. And one of the things that people do to kind of to reduce their cardiovascular risk factors is, it was common practice think, oh, just exercise a little bit throughout the day, park further away from your building, take the stairs instead of the escalator or elevator. And research is finding that's not enough for people. You need to have dedicated exercise time where you're doing 30 minutes of aerobic activity 5 days a week that's dedicated to that for you to really see some benefits and health. It's something that you need to be aware of. You need to tell your patients that, and especially with obesity and morbid obesity that we're just seeing an epidemic of it across the country, you really want to promote health to your patients. And let me see, is there any more that I can talk about cardiology? I know the salaries are really high above, I think the average is about $350,000 a year as a cardiologist. And the cardiologists I work with, they're like, yeah, you can make a decent amount of money, but you don't want to go into medicine for the money, as you hear oftentimes from specialists about it. And going further with that, it's not just about the money. You want to go into a specialty that you enjoy. You want to enjoy the patients you're working with. You want to enjoy the work that you're doing, because that's basically going to become your life. And if you're not having fun and you don't enjoy it, then you really should think about something else. But the cardiologists, they love the work that they do. You find out that the interventional ones, the EP guys, and the ones who do the pacemakers and all the implantable cardiac devices, they're a lot more hands on than your non invasive cardiologist. So that's something to be aware of. But cardiology, I think there's a lot of room to do a lot of different things in the field. The one concern I would say is that you have to worry about, you have the interventional cardiologist doing things for the heart, and then also the interventional radiologist. So there's a little bit of turf war going on there. And the way that technology is going and some of the advances that we have, if you're a cardiothoracic surgeon, there's you're not getting the volume cases that you want, because now we're doing things a lot more minimally invasive. So you're only getting the big cases where it's a bypass, where we actually have to open up the chest and do intensive surgery that way. But if it's a valve replacement, a lot of those can be done through a groin and a femoral, so you're not going to have to open it up, and the interventional can do that. And so that's just something to be aware of, the competition and the outlook for the specialty. But I think it's going to be very strong specialty to go in for the next years, decades or so, because the population's aging. People are going to always have heart issues, and I really enjoyed the specialty, and I would certainly recommend it to others who want a good mix of medicine and also procedures as well. And so that's all I have to say about cardiology. It was great. I had fun doing it, and I think it's something that you should definitely consider doing if you're a pre-med and you're not, or a medical student or pre-med, you're not sure what you want to do. Definitely take a look into cardiology and life as a cardiologist, because it might just open up your eyes and your heart to something that you want to do. And this is Jason signing off of DoctorPremed.com. Thank you.